Hello friends. I'll be talking on this topic, hyperbaric oxygen therapy, pathophysiology. So this talk I gave in Head and Neck International Conference in Delhi on 17th March in one of the Head and Neck Oncology Conference. So in this, I'll be mainly covering on the pathophysiology as to how HBOT works and what are the physiological effects of HBOT in various conditions. So the reason I'm talking is I'm a HBOT certified. So I trained in HBOT in 2007 in Royal Adelaide Hospital. So this is how the hyperbaric machines look. And this is one of the review article we published during COVID time on whether hyperbaric oxygen has a role in COVID. So let's just ponder on the history of HBOT. So HBOT was first sort of attempted in 1662 by Dr. Henshaw. But the person who is considered as the father of hyperbaric is Dr. Paul Burt, who established the science and application of hyperbaric oxygen. And at this point of time, there are 14 approved indications for hyperbaric. So briefly, I'll take you through the detailed indications. So the commoner indications as an emergency is carbon monoxide poisoning. The most approved or level 1 evidence exists in all the chronic wound, like diabetic foot to prevent amputations. It has a very good evidence, and anemia where you need to treat independent of the transfusions and to have a good sort of oxygen delivery independent of hemoglobin. It is an approved indication. And air embolism, it's an emergency indication, air embolism or central retinal artery occlusion. So these are some of the emergent conditions. And in sensory neural deafness, so there is an approved indication for hyperbaric oxygen. So most of the indications for HPOT are governed by underwater, undersea, and hyperbaric medical society. So all the science of HPOT is governed by the society, which is undersea and hyperbaric medical society. So the whole evolution of HPOT happened with decompressive sickness due to in deep sea divers. So that is where the absolute indication remains. So if you have to talk about indications for HPOT, you could broadly divide into four categories. So as I said, the first category is all the chronic wound therapies where you have to enhance the healing, and diabetic foot remains the commoner ones. So the second broad division or indication is where you would want to have angiogenesis or vasculogenesis or neurogenesis. So you want to have new vascular formation. So that is one group. And the third important domain, which is probably pertinent or intensive care, is antimicrobial activity. So like necrotizing fasciitis and chronic wound, which are secondarily infected. So that is the third broad dimension. But the one dimension which is life saving is all the medical emergency, all the emergent like carbon monoxide poisoning and all that I spoke. So when you talk about chronic wounds, all the chronic wounds, crush injuries, compartment syndrome, or myositis or myonecrosis and necrotizing fasciitis or chronic osteomyelitis. So these are all approved indications for hyperbaric oxygen. When we talk about vasculogenesis or angiogenesis, again, chronic wounds, the three things that trouble chronic wounds are hypoxia at the tissue level. Because of hypoxia, there is a lot of infection, so we need to mitigate that infections, and we need neovascularization. We need new granulation tissue and vascular formation. So all three components become very important in chronic wound. So, but the other distinct condition where we need, where there is avascularity is all the radiation injuries, like radiation necrosis. So, where the vascular supply is significantly compromised and HPOT becomes the mainstay of therapy in radiation, osteoradionecrosis and radiation injuries or radiation cystitis and so on and so forth. And HPOT is also established use in certain chronic infection or deep-seated like cerebral abscesses, osteomyelitis, and other infections where you want to reduce the infective burden, or where there is a implant infections, where there is biofilm formation, where you would want to have a significant impactful antimicrobial activity. It has an approved indication. Medical emergency, as I said, air embolism, carbon monoxide poisoning, central retinal artery occlusion, and the whole science of HBOT has evolved with decompression sickness in deep sea divers. So this is in broad about the indications, approved indications for HBOT. So now coming to what is the principles of hyperbaric therapy and how does it work? The theoretical basis. So it pretty much works on two laws, Boyle's law and Henry's law. So what it simply means is you increase the pressure because we all breathe at 1 atmospheric absolute. So that's the pressure we breathe. So in hyperbaric, the word hyperbaric is we increase the pressure. So we increase so that medical grade or therapeutic HBOT is often considered when we use pressures more than 2 atmospheric absolute. So we go up to 2.4 atmospheric and all medical conditions we use minimum of more than 2 atmospheric absolute. For wellness, we use somewhere between 1 to 2 atmospheric. So there are studies comparing between 2 atmospheres and 3 atmospheres. The sort of a ballpark atmospheric we use is 2.4 atmospheric. All the studies you would see would be done with 2.4 atmospheric absolute. There are studies which have even done looking at 3 atmospheric. So most of them have shown increasing up to 3 doesn't show any benefit. So what it simply says is you increase the pressure to more than 1 atmospheric. So the amount of oxygen in a given volume significantly increases. That's what Boyle's law says. So the density of oxygen increases in a smaller volume. So the dissolved oxygen also significantly increases in the given volume because of increase in the pressure. So generally, our oxygen transport happens in association with the hemoglobin binding because hemoglobin binds to oxygen within the RBC. So it is very much dependent on the RBCs and the hemoglobin level. But HBOT is independent of the hemoglobin. So you don't need hemoglobin because with increasing the pressure, there is direct diffusion of oxygen into the tissues and into all the tissues in the blood, and there is diffusion of oxygen which happens even in the lymph and in the CSF, so on and so forth. So the diffusion of oxygen is hemoglobin independent. So that is the key thing about HBOT. It is hemoglobin independent diffusion of oxygen, which plays a pivotal role in lot of anoxia or hypoxic condition. That's why it is an approved indication in anemia also. And so what typically happens is there's increase in the oxygen tension. So there is increased oxygen delivery, increased oxygen diffusion. And because there is increased diffusion, so there is improvement in the microcirculatory blood flow. So microcirculatory and capillary blood flow also significantly increases. And this helps in reducing tissue edema because there is increased vascularity. So the local hypoxemia also is mitigated significantly. So the second thing is there is something called total gas washout that happens. So so it is shown that just by taking oxygen in HBOT for 15 minutes at 1.75 atmospheric absolute. So you flush out all the inert gases from the cells because when we take air, we take oxygen along with nitrogen. So the whole nitrogen gets flushed out of the cells just by taking oxygen for 15 minutes at 1.75 atmospheric absolute. So which means you are enriching the cells with only pure oxygen and we take away the inert gases, which is nitrogen, because nitrogen forms a significant chunk of the inert gas. So this is a important thing for any of the intensivists who are interested in HBOT science. So just pay attention. So at 1 atmospheric absolute, we are all breathing in room air, 1 atmosphere. So the amount of oxygen in 100 ml of blood is 0.3 ml. But if we put ourselves on, say, NRBM, non-rebreathing mask oxygen or HFNO, and breathe 100% oxygen, so our dissolved oxygen in 100 ml is 1.8 ml. So now with 100% oxygen at 1 atmospheric absolute which we breathe, we have 1.8 ml of oxygen in 100 ml. But if you increase to 3 atm at 100% oxygen, the oxygen level in 100 ml blood is 5.4 ml. So that's the amount of increase in oxygen that you attain by increasing the pressure. It's a simple boil. So increase the pressure, increase the density of oxygen in the given volume. So that's the whole science. So then there is super elevated oxygen consumption. So this is also an interested physiological aspect you can just keep in mind. Normally, the amount of oxygen a normal person breathes in a day is 1.81 kg of oxygen per day. So if you had to just simplify it and put it in a balloon, so it weighs around 1.81 kgs in a day. But if you put HBOT, one session, which is at a 2 atmospheric absolute for 90 minutes, so the amount of oxygen in the balloon will be 6.35 kgs. So that is the proportionate increase in the oxygen delivery and consumption that you provide for a individual. So this is the physiological aspect of HBOT. And hyperbaric oxygen, as I said, it significantly reduces it has an antimicrobial effect. It is bactericidal. So, and it has a bactericidal effect as well. And it has detoxification because it flushes out the nitrogen. So, there's a lot of flushing of toxins also that happens with higher pressure with HBOT. So, these are the physiological aspects of HBOT. So, we'll talk about what it does at cellular level. So, this is hyperbaric oxygen. So, this is a penumbra after a stroke. So, in brain, what really happens is in someone who's had a stroke, it significantly shrinks the penumbra. So we all know when a stroke happens, there is a core area, as you see, this is the infarct core, and this is the penumbra, where the neurons have ability to reverse the injury. So where they are in a stunned situation, and the injury can be reversed. So HPOT helps in reversing the neurological sort of a damage that happens in the penumbra by activating the neurons and causing neurogenesis. So it does cause generation like vasculogenesis. It is helpful in formation of new nerve cells also in ischemic penumbra region. So hyperbaric oxygen with physiotherapy, with occupational therapy, and with speech therapy has shown to be extremely effective in some of the studies that in stroke or where there is ischemic penumbra. And HBOT is shown to mobilize the stem cells, pluripotent stem cells, and it is shown to significantly increase CD34 cells, which are required for vasculogenesis and angiogenesis and anti-inflammatory effects. So when we say what is the difference between vasculogenesis is a whole new vessel formation happens, and angiogenesis is a lot of microcapillary formation from the main vessel tends to happen, like collaterals. So that's the little difference. So it helps in mobilizing pluripotent stem cells and CD34 cells. So just again to see what it does at the cellular level, when you provide HPOT, hyperbaric oxygen, there is significant increases in the pulmonary oxygen level, and there is supranormal increase in the oxygen level at the alveolar capillary sort of a membrane, and this helps in significantly increasing the systemic oxygen delivery and tissue oxygenation significantly increase. This we have understood because there is significant increase in the oxygen at the tissue level, at the alveolar capillary level, and at the tissue level as well. So this significantly increases oxygen, and which as I said is hemoglobin independent because it is not dependent on hemoglobin to increase the oxygen, and that significantly reduces the hypoxic element. And this is shown to increase the reactive oxygen species and reactive nitrogen species production. And by increasing in the ROS and RNS, there are increase in the growth factors, and this has an immunomodulant effect and the angiogenesis. So this is sort of a conundrum that happens with HBOT. And if you have to make it more granular, so we divide it into what it does at the vascular level. So at the angiogenesis, it increases the nitric oxide level. There is increase in the factor called NRF2 factor, and this increases epidermal growth factor and vascular endothelial growth factor endothelin 1, and this increases the TNF alpha and matrix metalloproteinases 9 and tissue injury metalloproteinase. So these are some of the favorable ones which increase, which tend to happen at the vascular level. At the antimicrobial activity, it is shown to reduce the neutrophil activation and reduce the inflammation, and it does reduce inflammatory markers like IL-6 and IL-10, and there is increased killing of the bacteria, and HBOT has shown to have effect in dissolving the biofilms as well, especially in patients where there is implants with biofilms. HBOT is helpful, and there are a lot of studies and case reports and case series to show how HBOT has been effective, especially in orthopedic implant infections, chronic osteomyelitis, shown significant outcome and has salvaged the limbs. So it has a very significant antimicrobial. The logic is very simple. Bacteria thrives in hypoxic condition by supranormally enriching oxygen. So it significantly reduces the infection. So immunomodulation, it does increase the antioxidant effect, does reduce the inflammation, and it increases the natural killer cells and does reduce the interleukin 6 and does improve the Th17 cells. So these are some of the physiological effects that HBOT has. So its effect on wound healing. So if you look at the stages of wound healing, so initially there'll be bleeding, followed by inflammation, and then there is a proliferation and remodeling. So these are the stages of any chronic wound healing. So the problem we have with wound healing is at the inflammatory phase, because this is the phase where hypoxemia sets at the wound level, and the infection happens and delayed wound healing happens. So in chronic wound, there is hypoxemia that happens at this phase, which does not allow proliferation to happen and fibroblast formation. So HBOT mitigates this process. So HBOT significantly reduces, because your infection sets in at the time of inflammation when there is a local tissue hypoxia. By preventing this, it reduces the infection, reduces the inflammation, and increases the capillary formation here or angiogenesis, which helps in wound healing and fibroblast formation. It does increase the macrophage activation, angiogenesis, and it does reduce the intracellular adhesion molecules. And HBOT significantly increases the local nitric oxide, which increases the which reduces the intracellular adhesion molecule and reduces the inflammation. And it prevents reperfusion injuries. So this is some of the mechanisms involved at the wound level, how it enhances. And HBOT increases something called proline hydroxylase, which is required for collagen formation to help wound healing. So simplistically, at the inflammatory phase, it reduces the hypoxic element, and it increases the local nitric oxide, and it increases the local proline hydroxylase formation, which helps in formation of collagen, and there is good fibroblast proliferation that is facilitated. So this is sort of conceptual understanding as to how HBOT helps in wound healing. So there are a lot of studies. I won't go through all the details. So outpatient wound centers, 15 years back, there were around 100 in US, which is now there are HBOT centers, around 1,000 HBOT centers in US in the recent past. And as I said, 19th century HBOT was introduced for decompressive sickness. Later in 1961 to 62, it was used for carbon monoxide poisoning, gas gangrene. And 1977, so there has been a textbook that is come out. So just showing you as to how there has been the takeoff with regard to HBOT from decompression sickness. Now there are varied conditions for which HBOT has shown to be a very useful adjunct in influencing the outcome. So again, just to take you through the evidence-based recommendations. So there are divided into urgent primary therapy is your decompression sickness in diving and arterial gas embolism. So urgent adjunctive is these are the indications where it is used as an urgent sort of an indication as an adjunct. Carbon monoxide poisoning, crush injuries, gas gangrene, and retinal artery occlusion. Non-urgent adjunctive is all the osteoradionecrosis and radionecrosis of head and neck and radionecrosis due to radiation injury. Chronic wound, we have spoken about all the diabetic foot of various grades from 3, 4, 5, hypoxic wound, refractory osteomyelitis, and compromised skin graft. It is an approved indication. So this is sort of a rough overview as to approved indications where it is used as an urgent indication and urgent adjunctive indications. So just to give a brief as to how many studies have been done, as you see, as of now, there are around 8,194 articles published in HBOT, and 440 articles are on chronic wound healing, 59 articles are on flaps and grafts uptake, 121 articles on osteomyelitis, 26 sort of a text reviews on chronic wound healing. So this is the body of evidence as of now that is available. So HBOT, there's a lot of science that has evolved, a lot of evidence that has been collated in the recent past with regards to various conditions on the utility of HBOT. So one important indication, since we are talking on the head and neck conference of cancer. So how about in radiation oncology? So the approved indications is radiation necrosis and osteoradionecrosis, where there is no way that you can get the healing happening because of the vascular compromise, and HBOT remains the mainstay in these conditions. And even it is used in a prophylaxis where there is a suspicion of healthy tissue radiation. And what is most importantly advocated is pre-radiation giving HBOT sessions has shown to increase the effectiveness of radiotherapy. So now HBOT, there's a lot of studies that are being done where HBOT is being used as an adjunct to radiotherapy, pre-radiotherapy to increase the uptake. And even it is used as an adjunct with chemotherapy, where the effectiveness of chemotherapy can be significantly pronounced if it is given with HBOT as an adjunct. So this is where a lot of studies are happening. So we won't get into the details of those studies. And radiation induced cerebritis and all the radiation cystitis, radiation myelitis, radiation pneumonitis, HBOT remains the mainstay of treatment, or optic neuritis. So any of these inflammatory conditions related to radiation, HBOT appears to have a significant benefit. So I'll just take you through examples where we have done HBOT in our own center. So this is a patient. This is all these patients are the patients we have treated in our HBOT center. So 58-year-old male with a CA buccal mucosa who's had a surgery. So this is the picture of the patient and who had chemotherapy and radiotherapy. So we gave HBOT at 2.5 atmospheric absolute for 90 minutes for 20 sessions. And the main complaints this patient had, as you can see, is pain and swelling at the side. He had pus discharge and he had difficulty in speaking and he had obviously difficulty in eating solids. These were his problems, which was limiting his daily activity. And you can see post HBOT, after 10 sessions, there was reduction in pain and swelling. After 10 to 20 sessions, as you see, pus discharge has stopped. After 20 sessions, flap was fully healed. So that was a good outcome we had. And so this was another patient, 37-year-old lady who had a salivary gland cancer. So post radiotherapy had a non-healing ulcer. So we gave HBOT at 2.5 ATA atmospheric for 90 minutes for 20 sessions. So obviously post HBOT after 10 to 12 sessions, the pain and swelling significantly came down. After 20 sessions, the ulcer healing with good proliferation and maturation phase happened. So we had one case with AV malformation. So 58-year-old male with no comorbid had a AV malformation. So had a surgery with groin flap repair with a non-healing because these are venous ulcers which do not heal well. And patient had difficulties in activities of daily living. So HPOT was given at 2.5 ATA for 15 sessions for 90 minutes. After 5 sessions, swelling came down and there was an enhanced healing. So that's the whole science of HBOT. So HBOT does hold promise in various conditions. So summarily, level 1 indications are all the chronic wounds or vascular wounds. And there are lot of studies happening in the oncology as an adjunct for radiotherapy and as an adjunct to the chemotherapy. With regards to stroke and traumatic brain injury for neurological recovery, there are good studies, but I wouldn't say that the evidence is so robust that we can do it as a standard of care. But there are a lot of anecdotal reports and case reports citing its benefit with regards to improving their neurological and cognitive status. So thank you one and all. You can visit my website to rehear to this lecture. So thanks one and all.